The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and we want to welcome you to Friday and our Safe and Calm webinar for September 18th, 2020. So late yesterday afternoon, CMS issued their visitation guidance, which kind of undid the entire content for our webinar, but it bodes well for our residents, at least in our nursing homes. And before we get started, I did notice right before we began the webinar that there were some topics running back and forth on the listserv about whether or not MDHHS guidance would be superseding this because it's more restrictive. And it's kind of a complicated system in terms of figuring out when there's conflicting guidance from states and the feds, which would rule. But CMS has purview over Medicaid and Medicare certified nursing homes. And so their guidance and their requirements must be met. So when we were talking about testing, and they came up with a requirement that facilities with such a positivity level had to be tested only monthly. But the state says they have to be tested weekly based on their numbers. The state can do that. They can extend CMS's rule because CMS's rule was met. But this is an entirely different situation. CMS has identified that visitation is a resident right. And so MDHHS is not going to be able to work around that and put more restrictions than CMS did on that right. So it all depends on whether or not the CMS rule's been met. That's the way I would hope that everyone will think about it. So when this came out last night, of course, very excited. We contacted the department immediately because we know that MDHHS does not get all of the information on about surveys. That's a LAURA issue. We want to make sure they knew about it and anticipated it, and we let them know that it was our thinking after reading through it that this is not something that MDHHS can supersede, and they should be ready for some questions. And they had not, of course, reviewed it yet, and they're going to do that. What's very hopeful here is that as far as we're concerned, these CMS rules will be applied and they are effective immediately. So surveyors are going to start in the next month or so looking for compliance with this. That kind of puts the department in a position because it's really hard to have stricter rules for independent living and assisted living level kinds of care than you would for nursing homes. So we're going to use that point as an advocacy piece to try and help the department move forward in a more positive way and consider the well-being of our residents. So having said all that, for today, our agenda, we're going to be providing a very brief advocacy update, and then we will be reviewing the MDHHS first iteration of outdoor visitation questions. So a couple days ago, maybe only one, I don't remember, the time flies so fast. The department put out visitation frequently asked questions based on that outdoor visitation rule that they issued last week. And for a moment, we considered not including them because to some degree they're moot. But they are only not going to cover nursing homes at this point. So other facilities, unless the department changes the rules, are still considered covered under the outdoor guidance. And again, we hope that will change, but for right now, that's still in effect. So we're going to go through those visitation FAQs. It's pretty short, and actually the answers are pretty easy for this one. Then we are going to review the CMS visitation guidance for nursing homes, and we're going to end a little bit in talking with cohorting. So with that, we'll turn the presentation over to Dalton, our Director for Public Policy.
Good morning, everyone. I have a fairly brief advocacy update this morning. I just wanted to touch quickly on the legislative calendars coming up, Michigan and nationally. It's important to note as I go over this that each of these bodies is facing some sort of pressure because they're trying to get some sort of large financial package passed. So in Michigan here, they're scheduled currently to go until the 24th. And they have until October 1st to pass a budget. They do have days scheduled to go until the 30th, or temporarily held to go past the 24th if they need to. Every day is held after the 24th. So they do have a couple days to work it out, the budget that is, but they do anticipate that they'll get something done by the 24th. We'll see. I do have some positive news to share though. I have heard from a fairly reasonable source that the total cuts to the DHH budget, which is where a lot of long-term care is, that budget's what a lot of long-term care is funded through, will only total 15 million. That is, well, 15 million is a lot of money. To that budget, that is not a lot at all. Nationally, they are working on the 5th COVID-19 stimulus package. They just got another draft in the House that kind of takes both political parties' agendas into account and sort of meets them in the middle. They are scheduled right now to go until early October, both the House and the Senate. But the Speaker of the House, Nancy Pelosi, has said that she will keep the House open until something is passed. And the President has indicated that he would like to get something done quickly here. There hasn't been any public statement yet from the Senate, but I'm sure they are eager to get something done too. Moving on, I just want to review the nursing facility infection prevention and control grants because of the question that was on Wednesday's call. So we won't be going over every slide here in detail as you'll have them and we've covered them once already, but we'll just run over it in general and then cover what the department thinks you should be spending these funds on. So the purpose of these grants is to support permanent improvements to a facility's equipment to achieve more effective prevention and control. And these funds can pay for a portion or all the costs of that infection control equipment, and only Medicaid certified nursing facilities are eligible. It's also important to note that this money goes away by December 31st, so the department is accepting ideas other than those that they have listed in the application. So if you do think you have an idea that would help your facility meet infection control standards, please feel free to apply. They're looking to get this money spent before it all goes away. The next slide shows how much your facility can be awarded. This is dependent upon if your facility is in a high or low poverty area. The application itself actually tells you which facilities are in high poverty areas. And then there is also the grant process here on the bottom of the slide. Essentially, you have to submit the application by October 31st. The applications are then reviewed. You'll be notified of the approval, and then the payment will be made through a gross adjustment within 2 weeks of that approval. And then you need to submit documentation of those expenditures by February 1st of 2021. This is the review criteria that the state will be looking for. So if you do think you have a more creative idea than those listed on the next slide, this is kind of the criteria which you need to fit that purchase to. So keep these in mind when you're looking for purchases outside the listed ones. So here is that list of suggested purchases for your facility. There's energy recovery units, portable UVC units, HEPA filters, an HVAC retrofit to accommodate higher efficiency filters, upgraded exhaust fan systems, physical plant enhancements for visitation rooms, electrostatic fogger with biostatic virucidal cleaner, photocatalytic oxidation units, touchless hand sanitizer dispensers, and touchless forehead temperature scanners. And then here's that example that I think helped everything make a lot of sense to me. Uh, grant funds may not be used to replenish infection control supplies used in normal operations, but not limited to, including but not limited to PPE and cleaning supplies. And the example that helps make a lot of sense to me was the idea of the touchless hand sanitizer dispenser you can purchase, but not the hand sanitizer itself. So that's how I like to think about this. So if you can think of something that meets the review criteria, the department is looking to spend these monies by the 31st. So I do encourage you to apply if you need any of these specifically, or if you have a more creative idea to help your fiscal plan be more effective at infection control.
All right, thank you very much for that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo during our annual conference. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. So I kind of have a mix of questions right now. I think that a couple will probably be more pertain to what Deanna said at the beginning of the webinar, and then I have a couple for you as well, Dalton. So the first two, I believe, will be for Deanna. So this says, meanwhile, if we are AL and IL, we just continue to follow MDHHS EPI order.
Yes, you're going to be required to do that. Hopefully, they're going to change that guidance. We're going to strongly advocate for them changing the guidance, but right now you are still covered under it.
Okay. And then I have a question about HFA testing from our last webinar. If you conduct baseline and have a positive, and then you test again and have no cases, when are you supposed to resume testing again after you have 0 cases if you remain in the mid to high zone in the Michigan Safe Start map? Do you just continue with weekly even if all negative and only stop based on the map change?
If you're going to test based on the rules for basically nursing homes and other entities, remember it's not required, but when you're in a fairly high area of transmission, it's recommended that you go and move forward to weekly testing for staff, not residents, but staff. Residents should only really be tested if you have an outbreak or they have symptoms or you have some reason to expect or suspect that they might have COVID.
Okay. This one is for Dalton. Why do you think the respective legislative sessions are ending? It says ending 4 already, but I'm guessing maybe just ending already.
I assume we're talking about the state level. They are ending because we have an election in November and they need to get out and spend some time in district campaigning. That's the large reason. Another thing is that the budget is due October 1st, and after that, normally they wouldn't be moving a ton of legislation until election season, just because they don't want to put their name on a bill package or something that proves unpopular in their district and risk something at the last minute. You often see this in lame duck unless like the party has some kind of thing they want to get pushed through at the very end.
All right. Thank you, Dalton. All right, so I think that these questions are going to be more towards Deanna. My question was regarding the CARES Act nursing home infection control distribution. What does hiring staff, whether employees or independent contracts, to provide patient care or administrative support, one of the permissible expenses mean? Seems very broad.
Actually, off the top of my head, Dalton, is that something you could cover that's not something that I have filed in my head?
Can you read that again, Blake?
Yeah, no problem. So it says, my question was regarding the CARES Act nursing home infection control distribution. What does hiring staff, whether employees or independent contracts, to provide patient care or administrative support mean? It says that it's one of the permissible expenses and seems very broad.
So I assume this is the second distribution of those CARES Act support funds that came out think a couple weeks ago. I don't know off the top of my head. That does seem broad to me. I will review the guidance and get back to you in the Q&A.
All right, sounds good. Deanna, I do have a few more questions for you. Do you want to go over those now or wait until you go over your section for the
I
next?
think, why don't we go through the visitation guidance, and we're going to pause right after we go through the CMS visitation guidance, and I'll take those questions then.
All right, sounds good. So we will move forward then.
Okay, so however, before we get to the CMS guidance, we're going to spend a little bit of time talking about the MDHHS responses to questions that result from their September 10 epidemic order. As we reviewed these, and they came out a day or two ago, one of the things that we noted was that they seemed to be the answers to the easier questions. I think they put out the easy answers first. So we're going to go through them really quick, remembering that in general, most of these will not apply to nursing homes from this point forward, but some of them do. So we're going to start with that, and then we'll go to the CMS order. So the first question was, had to do with facilities covered under the guidance, and I think we're all aware of which facilities are covered under this guidance. The second piece is last week, one of the issues we had, or at least that I personally have difficulty with, was that there's separate statements in the department's testing Q&A for nursing homes, and this will still hold, but testing Q&A will still hold. One part of it says to test all contractors who come into the building routinely. Another answer says test all contractors who come into the building and spend at least 8 hours there in a week and have direct resident contact. So we have asked for better guidance and a suggestion that they identify the bottom line here. So according to this response, all contractors spending 8 hours in a facility must be tested. So that's a little bit better than just testing everybody, but they don't discuss the direct resident contact part here. So I was more confused than I was before, and so we're going to ask this question again. This question, as it was stated, was not ours. I think they haven't gotten to ours, but we would like one clear requirement for this element. Another question was about allowing indoor visits for persons with hearing or cognitive issues. And the response was only outdoor visits currently are allowed, but a person with hearing or cognitive issues who would fall into an exception category if they were negatively impacted because they couldn't communicate, or in somehow or other in-person visitation might help them with some of their ADLs, then they would meet the exception criteria. But just allowing indoor visits for persons with hearing or cognitive issues, no. This visitation guidance was really about outdoor visits. The order uses the word whenever possible. So it kind of questions whether or not indoor visits would be allowed if outdoor visits were not possible, and of course the answer is no. The idea is that the visitation guidance allows outdoor visits now and only allows indoor visits for those few exceptions. The next question is about same visitors from the same household, and the answer is no. They do not have to stay 6 feet apart from each other, but they do have to maintain distance between them and the residents or staff. The guidance also talked about the local health department and their responsibility to identify further visitation restrictions if there's a surge or something happening in their area, and that would preclude a facility's ability to have outdoor visits. Facilities, though, do not have to contact the local health department for that information. It is the local health department's responsibility to notify you, and the department has let them know that. Another piece is that what is meant by observing and ensuring compliance by the staff monitors or supervisors of these visits. And that means that they simply have to remain in sight. And we do know that you're allowed to supervise more than one visit at a time as long as you can help ensure compliance is being maintained and have full sight of the visit. And this last one says if outdoor visits are not feasible, can you use resident rooms or other designated locations? Under what circumstances are those allowed? And again, the guidance is really meant to extend visitation to the outdoors, and only indoor visits that meet those few exception criteria are allowed. These next set of questions have to do with beautician services. They can be provided as long as lack of the service causes negative harm to the resident. A physician order is not necessary for that, thank goodness. Obviously, in general, beautician services would be provided indoors, but there are other services that could be fulfilled remotely or out of doors. Remote services could be clergy services. So there are other services that are appropriate remotely, and there are a few that could be done out of doors as well. And facilities should document the need for beautician care by considering the resident's physical, psychological, and emotional well-being, which I kind of thought was a very general answer. I would think that dignity and feeling of worth, which was in this question, would qualify within that. So you just need to document it. You do not need a clinician or a physician to do that, thank goodness. Okay, so those are the MDHHS responses to the outdoor guidance as of yesterday. And except for the testing one, they really don't apply to nursing homes any longer. CMS put out S&C letter 2039NH, and it supersedes previous CMS guidance for visitation. And as written, it also supersedes all MDHHS rules for visitation in nursing homes. I could not find one area when I reviewed it that the department would be able to extend or expand restrictions for. And as I said before, figuring out whether to follow a state or federal regulation is not always easy. It depends on the content of the rule and how the two rules interact. So the rule states that visitation can take many forms. It can be in resident rooms, in dedicated indoor visitation spaces, out of doors, and for reasons other than just compassionate care. So they really are opening into some limits, but they're opening up visitation to a whole a new set of areas. For all visitation, however, CMS requires adherence to the core principles, which we have always called safety precautions. And those that they listed in the guidance and that are listed here on the slide are the common list. We all know kind of what those are. We won't go through that line by line. But throughout all of the visits, except for a few exceptions that they note down later, you have to maintain all the safety precautions for all the visits. So visitation in CMS's view should be person-centered. It should consider the needs of each resident. The commission report, which we've not really talked about because other things keep jumping up and kind of are higher on the priority list, which came out a few days ago. The commission report influenced these requirements. And they actually suggested that each resident have a visitation plan and a communication plan explicitly identified in each resident care plan. This doesn't actually say that, but you might want to consider how you're going to document person-centered visitation otherwise. We understand the rationale for being person-centered and supporting that, but the commission's recommendation that a visitation plan and a communication plan be explicitly in each resident care plan felt a little burdensome to us, but is not stated as such in this guidance. Some other things is that risk of transmission can be further reduced through use of physical barriers, so that they're encouraging use of things like plexiglass, indoors, outdoors, doesn't matter, to further reduce the chance of transmission for these visits. The guidance does state that visits should be conducted with an adequate degree of privacy, and this does bump up against the MDHHS visitation rule for supervised visits. There's nothing in this guidance that mandates supervision. Although facilities are supposed to ensure that compliance to the safety precautions, or what they call the core principles, is maintained. So that might not be easy. Persons who do not adhere to these safety precautions are not allowed to visit. But do note that these visits, with a couple small exceptions, are really not intended by CMS to be supervised. And we'll talk about those few exceptions in a few minutes. Even in this guidance, though, outdoor visitation is always preferred whenever possible. And it should be the preferred type of visit, excepting for when there's inclement weather, resident health status issues, facility outbreak status, other things, anything that makes the outdoor visit not workable. You should try to include as many outdoor visits as you can. And facilities should have a policy that identifies the number and size of visits that they're going to allow. There is no CMS provision that states the number of visitors at any given time, like there was in the MDHHS guidance. So when outdoor visits are not feasible, indoor visits can be allowed, and pretty much for any reason, as long as certain rules are met. There can be no new onset of COVID cases for the past 14 days, and the facility is not currently conducting outbreak testing. So you can't have an active COVID situation in your building for indoor visits. Visitors, again, have to adhere to all of the safety precautions, and facilities should monitor persons who may have difficulty following them, such as children. So there is some overview and oversight required for those kinds of situations. Facilities are allowed to limit the number of visitors per resident and the total number of visitors in the building at any time. Visitor movement in the facility must be controlled, and visits should be made in private rooms or designated areas. But CMS also notes that if it's not reasonable for a resident to leave their room, such as for health status, or perhaps end-of-life care, something like that, they can enable, in other words, the facility can allow in-room visitation in shared rooms if they adhere to all the other safety precautions. Facilities must use the county positivity rate to determine when to allow indoor visitation. Remember that these rates are listed on the Nursing Home Compare website, and they're updated weekly there. When last I looked, there were no counties in Michigan with a 10% positivity rate, and I think there were only 5 counties with higher than a 5% rate. So that means that indoor visitation would be allowed unless the positivity rate is higher than 10%. One of the things that facilities might consider is if, especially if they're on a border to another county, they might want to look at the adjacent county rates to make their visitation decisions. And they can look at other indicators of high transmission to help decide the appropriate level of visitation as well. Another piece is that CMS does not distinguish between the kinds of persons allowed to be visitors for indoor or outdoors. So it doesn't have to be those essential caregiver people. All of the rules apply to all of the visitors just the same. CMS suggests, but doesn't require, that visitors be tested if the facility is in an area of medium or high risk. And remember that The definition for medium and high is a little different for CMS than it is for Michigan. And if you are considering visitor testing, facilities should prioritize those who visit regularly. And of course, visitors can always be encouraged to do testing on their own and show you documentation of what the results are. Compassionate care is allowed no matter what the county positivity rate is. And CMS has expanded what compassionate care means and provides a lot of examples in the guidance. Compassionate care is always allowed. Indoor visiting is allowed anytime you don't have a 10% or higher positivity rate. So anyone who needs help with ADLs is listed under compassionate care here as well. Persons who are struggling with isolation or mental health problems, who would be positively impacted by a visit, they're included here. And if during a compassionate care visit, it seems appropriate for physical contact, CMS says they should, the facility should allow that physical contact while maintaining all other safety precautions and having that physical contact be allowed only for a very limited amount of time. So it seems that CMS is really being responsive to resident well-being here. The visits are meant to be person-centered. Facilities should be discussing resident needs and options with the resident, family, caregivers, and other stakeholders. And along with the ombudsman, if indicated, to create a plan that works for each resident. So you're really going to have to look at individual resident needs. With the idea, though, that indoor visiting is pretty much allowed here. Facilities, you can move to the next. Facilities still have the right to restrict visitation based on the rules discussed earlier, the county positivity rates, presence of COVID in the facility, etc. But facilities cannot restrict visitation without a reasonable clinical or safety reason, cause. And this is the piece that really precludes MDHHS from further restricting visitation beyond what is listed here. If the positivity rate is low, if you have no active cases, the nursing home must facilitate in-person visitation consistent with these guidelines, or you're going to face a citation. So, you know, it's like we went from restricting visitation on one day to mandating visitation the next, but it is in the best interest of the consumer, so it feels rather good. Persons on transmission-based precautions should only receive visits that are virtual through windows, and that includes persons in observation. Remember that persons in observation are in transmission-based precautions. So the only time that someone in observation should be receiving visits other than virtual or window visits is if they qualify for compassionate care situation. Otherwise, they are just like anybody else in transmission-based precautions. The guidance also reviews the rights and responsibilities of protection and advocacy programs. We do have a protection and advocacy. Oh, I'm sorry, I'm ahead of myself. I'll go back. Don't go back. You're in the right place, Blake. First, the ombudsman, and then protection and advocacy programs. The ombudsman can have immediate access to a resident. Although in-person visits can be limited if there are infection control concerns, but you have to have a reasonable cause for that. The ombudsman must adhere to the same core principles or safety precautions, as we call them, as everyone else, and they have the right to review medical records. But when there's high transmission, their visits can be done remotely by phone, etc. Okay, now the next slide. So the guidance speaks to protection and advocacy programs, and as I was saying before, we do have an agency, I think it's called Michigan Protection and Advocacy in Michigan. And these agencies are funded by the federal government to protect the rights of persons with disabilities. They also have the right to access all residents, either in person, by mail, or by phone. The A requirements are also still in effect, and facilities must provide assistance as needed for effective communication. The guidance says if that assistance is only available through outside staff, in other words, you don't have the ability to assist with this communication internally, and if that assistance has to be done in person, those staff persons must be allowed to enter the facility, with the only exception to that being legitimate safety measures based on transmission risk. So in general, you have to let those persons assist and come into the building as well. Healthcare workers who provide direct care as contractors are permitted to enter the building as long as they meet the screening criteria. Of course, along with all the other guidance, EMS personnel do not have to be screened. All staff and external healthcare providers must adhere to the safety precautions and the COVID testing requirements. We're still not sure how this bumps up to the rules that MDHHS has about testing, because again, this guidance just says people who come in routinely have to be tested. So we don't know how the weekly rule, the 8-hour rule, and the direct resident contact rule are going to bump up against that. So that's an area that we have to clarify, and we will re-ask that question if the department doesn't answer it soon. So more good news for nursing homes, really. Communal activities and dining can occur as long as, again, the core principles are met. Persons can eat in the same room, but facilities can also look at the need for some safety precautions based on COVID transmission within the facility. So if you don't have any COVID transmission, you can go ahead and restart some of your communal activities as long as you are complying with the social distancing and other infection control precautions. But if you have a lot of COVID transmission going on, you're going to have to look at that a little bit differently, depending on where it is and how heavy it is. Group activities can be provided for residents who have met the criteria to discontinue transmission-based precautions, who may not be in isolation or observation at the time. And of course, you don't want group activities for anyone with suspected or confirmed COVID status. Otherwise, you can allow those group activities as long as the safety precautions are adhered to. So, of course, based on all this, surveyors can cite you for deviation from these guidelines, and of course, the memo outlines how they can do that and which F tags to use. You can move it, Blake. Last but not least, in this section, the guidance confirms the use of CMP funds. And we remember that CMP funds can be used for electronic communication devices, etc. But now this guidance also adds that funds can be used to help facilitate in-person visits, help to buy tents for out-of-door visits, can be used to buy plexiglass barriers, etc. Things that will help with ensuring or at least minimizing transmission. But since this guidance is less than 24 hours old, we of course are sure that the department has not figured out the process for applying for these additional funds. But as soon as we find that out, we will let you know. Okay, now we'll take some questions.
Yes, they are starting to roll in. I've seen quite a few repeats, which we will get to. Has there been any reconsideration given to false positives?
I guess I'm not sure of the context for that. My understanding for point of care antigen testing false positives, the thinking is that the false positives that they recently identified are in alignment with the accuracy rate known to be associated with each of those tests. So we always knew that there were some accuracy issues with point of care tests. I think that the best thing to do, and the recommended piece, is that you follow up point of care testing based on that CDC algorithm that we went over a couple weeks ago. And if you do that, I think you're doing the best that you can. The beauty of the point of care test is that it can tell you quickly if someone is positive. And it is possible to have some false positives, but you have to look at the clinical situation and figure out if the person doesn't look symptomatic, or if there's you're an area of low transmission, then you know how to retest using a PCR test. But you still don't have to retest everybody simply because you're worried about false positives.
Yeah, she said that it was PCR, not antigen, and it was confirmed by the laboratory that it was a false positive.
Okay, well, those are relatively rare, and I don't know that there's anything that you can really do about that. There's always going to be some errors in almost any kind of testing that you do. Other than that, I don't have any guidance about false positives in PCR.
Okay, let me scroll back up here. HFA testing, if we have already done a baseline testing in April, do we need to do another round of testing now since the MDHHS recommendation was issued?
Using the same protocol that they did for nursing homes, which is what basically they're recommending here, you only have to test everybody once. If you have new residents that were not tested the first time, you might consider testing them. Other than that, the plan was to just start weekly testing of staff, I believe, would be the next piece, next step in the protocol.
All right. Someone asked, where's the link to the MDHHS FAQ? They did not see it.
We can send it to you. I don't think I put it in there. The thing that, in order to find it, all you have to do is Google Michigan HFA AFC, and the web page with that link will come right up. But we will send the link out again.
All right. Can you reiterate if Michigan is to follow the MDHHS or these new or this new CMS guidance?
Well, we haven't gotten confirmation from MDHHS, but when we talked to them last night, we let them know. They had not reviewed it, of course. We let them know very clearly that it was obvious to us that this guidance was going to have to be followed. The CMS guidance was going to have to be followed. And in fact, you will get cited if you're a nursing home, only if you're a nursing home. You'll get cited if you don't follow this guidance. So we've still not heard from them yet, but surveyors are going to be out in a couple weeks looking for these pieces. I imagine that there'll be some allowance for some transition, but that CMS rule was effective immediately.
All right. Yeah, that takes care of quite a few questions. A lot of people had questions of whether this it oversees the governor's executive orders and then the MDHHS stuff. CMS on 9/17/20 is allowing indoor visiting in resident rooms. Does Laura also allow this, or are they still limiting via governor orders visiting to outdoors?
We've not talked to Laura about this at all yet, but we anticipate that those memos, as they come out, are directions to their surveyors. They have to obey the CMS guidance. So there's no question in my mind that they will be looking for that. Now, when, I don't know. We will try and contact them and kind of get an update. And I'm sure that they'll probably put out something or communicate something about the near future. But yes, Laura's going to have to follow that guidance because those are the direct instructions to their surveyors.
Okay. Does the governor's order and state licensure also permit, just scroll down, also permit communal activities and dining as required by CMS?
No. No, they don't. In fact, all of the guidance pretty much still says no communal dining and no group activities. However, I think the CMS guidance will supersede that for nursing homes, but of course, still, again, not for all the other settings.
All right. If there are CMS rules applying to SNFs, is there a basis to apply them to AFC and HFA also? Does not seem appropriate to restrict in one setting and not another.
Exactly, and that is our advocacy point. MDHHS has the right to do that. They have the right to leave those rules alone, but we think that this is a good point to be making, and in fact, we will be referring them to the commission report as well, because the commission report suggests that we need to focus a bit more on resident well-being and a little bit less on fear of transmission. Not that both of them aren't really important, they are, but it has to be a balance, and that's what the commission report focuses on, and that's what we will focus on when we talk to the state. We think that this is a good point to maybe drive that home, and hopefully they will change their guidance for the other settings as well.
All right. When are the new CMS visitation guidance effective? Immediately?
Technically, they're effective immediately. I don't know. Again, we've not talked to Laura. We don't know when the surveyors will start looking for that, but they're effective immediately.
Okay. Does the department reimburse testing costs for volunteers?
I don't know that off the top of my head. We'll have to research that one.
All right. Any guidance yet on isolating residents that go out for required appointments?
Yes, you have to. You have to isolate people who go out for required appointments in nursing homes, and you have to use full PPE because they're going to be in transmission-based precautions. And we're going to talk about that in a little bit.
Should we immediately change our policies for the SNF to reflect the CMS guidance or wait for clarification from MDHHS? And also for ALIL, we just have to continue with current MDHHS guidelines at this time?
You know, I don't think that you can turn over your visitation planning in, you know, a minute anyway. I would start working on your policies, and I would start planning on how you're going to do this. You're going to have to notify your residents. So it's going to take a little bit of work in terms of the logistics of this. I would give yourself a couple days and see what MDHHS does. And yes, the sad part is you still have to apply the department's guidance for those other settings.
Okay. Will residents need to be placed in isolation for 14 days after they have a visitor?
No. No, there's no requirement for that.
Okay. Deanna says weekly testing until all staff and residents are negative for 14 days since the last positive test. So I guess that's just more of a comment.
That's true.
Would a resident be allowed to have a visitor every day, or are there restrictions on the amount per week?
That is something that you need to decide yourself based on, I would think, your ability to handle visitation. Outdoor, of course, is preferred. If you've got people who are not in private rooms, designated areas are required, unless there's some special circumstance. So that's pretty much a facility decision. The CMS did not identify any requirements in terms of number of visits. I think that the expectation is that it be reasonable, but we all know that that's rather a vague word. So you're going to have to look at what you think you can handle and what your capacity and capabilities are, and go from there.
Okay. For nursing homes, are there any part of the MDHHS visitation guidance that still apply to nursing homes in light of the CMS guidance superseding it that you can point out to us?
I looked for that when I reviewed it, but remember, I've only had, 12, 15 hours worth of guidance myself. I did not see anything that I thought would supersede it, other than testing, of course, still applies. And anything related to that, when you talk about people who are moving in and out of the facility, those things apply. But no, I think that for the visitation part itself, I couldn't see anything that I thought the department would be able to still restrict.
Okay. Are the visitation FAQs different than the HFA AFC FAQ?
Yes. Yes. The HFA AFC FAQs come out of the Bureau of Community and Health Systems over at Laura. These visitation FAQs came from MDHHS. I think we sent out a link to them the other day, but the ones that are, I listed all of them, so they are on the slides. The actual question is on the slide. Now, sometimes I abbreviated the answer, but the actual question's on the slides if you want to review them that way.
Where are the visitation FAQ?
The visitation FAQs, we sent out a link. I thought I just said this. We sent out a link a couple days ago. We can give you the link again. Off the top of my head, of course, I don't have it. But they are embedded in the slides here. So the FAQs that we just went over before we did the CMS thing, all of the questions that they put out are listed in those slides, although I did abbreviate some of the responses.
Thank you. Sorry to ask again, but one more time for clarity, we need to start following the CMS guidance for SNF immediately, and is it Leading Age Michigan interpretation that we can follow the CMS guidance for HFA and AFC as well?
No, you cannot follow the CMS guidance for HFAs and AFCs. Not at this point, not until the department changes their rules. Yes, I would start applying the rules if you're a nursing home, but it's going to take you a couple days. So you need to get your policies in order. You need to talk to your residents. You need to figure out how you're going to do this. That's going to take you a couple days anyway, I would think, and then I would hope that MDHHS would have some guidance. But again, I want to say again, those CMS nursing home rules do not apply to anybody else but nursing home.
All right. HFA staff and resident COVID testing is still optional, right?
That's correct. It's recommended but not required.
Okay. For the CMS guidance, is it correct that there does not need to be direct oversight of the visit due to privacy requirements?
That does appear to me to be said in the guidance. There is some kind of squishy area where you are supposed to ensure that that people are maintaining safety precautions. But there is no statement in there that says you have to have someone in view of a supervisor or a monitor of those visits at all times, not at all. And so I think the idea is that in general, you need to make sure that people are maintaining the rules for safety and infection control, but there is no allowance for ongoing supervision.
All right. It looks like that was the last question, so we can go ahead and move on. But before we do, I just wanted to let any of our members know who are enrolled with the compliance store that they have already posted sample policies up on their website if you wanted to check that out. But now we can go ahead and move forward.
Okay, so I did not anticipate time very well here, and so I would say that we have quite a bit of detail here on cohorting. And it is 11:55 according to my clock, so I don't want to go through that today with you because it's a lot of content. But I don't know what slide it is, so I don't think I'm going to move to that slide. I do want to let people know that for nursing homes, again, and we said this a little bit earlier, part of the dilemma with all of this guidance is that the CDC recommends. They don't require a whole lot. They recommend 50,000 things. CMS requires you to follow a lot of those recommendations. And CMS also has some words in their guidance, like preferably a observation unit, but you can use a single room if needed. But the surveyors do not follow line by line all of those gray words. And so one of the things that we found, and we have had confirmation from people who've been cited for this, that for people who are moving in and out of a facility for any reason, medical appointments, dialysis, etc., have to be placed in transmission-based precautions for 14 days, and that means full PPE. Now, we will continue to talk to the department about the realities of that, but people are getting cited. Another thing that people are getting cited for is that even though it says, you know, for someone in observation who's coming in to your facility from a hospital who's not COVID, but has to be in transmission-based precautions for 14 days, a single room will not suffice. You have to have a dedicated unit for those persons, even if you don't plan to have any dedicated units for your COVID positive patients. If you don't plan on taking COVID positive patients, number one, you have to plan in case of a surge what you're going to do. And number two, you have to have a dedicated unit for new admissions. A single room all by itself or scattered throughout your facility will get you a citation based on recent experience. So those are the two key pieces that I want to make sure that everyone's aware of, nursing homes only. And then I will talk about cohorting in the future. And Blake, I will ask you to move to like the third to last slide.
Let me know.
Next one. Next one. Okay. So we wanted, no, go back.
Okay, I'm sorry.
Okay. So we wanted to make sure that you knew of a couple of events coming up. Admiral Giroir is going to speak to the issues around antigen testing during the Leading Age Monday call at 3:30 p.m. There is a training with BD today at 3 for people who have that type of POC test. The Quidel group is going to have a training on September 24 at 3 p.m. And all of the links for these I sent out this morning in all the listservs. False positives we talked about in terms of point of care testing. Avid cards have been shipped to nursing homes and assisted living, but you're only going to get a card, those card tests, those really easy point of care tests, if you have a CLIA certificate. If you have a CLIA certificate, the feds know it. So if you're in assisted living who are thinking about this and you don't have your CLIA certificate yet, you're not going to get these tests. So please, if you anticipate doing these tests yourself, you should be applying for a CLIA certificate. And we did talk about how to access that before. And last but not least, there's a CMS National Stakeholder Call today at 1:30. And I don't know how you all are just absolutely overwhelmed, because I know I am. So anyway, it is Friday. Any last questions?
All right. It looks like we have a couple that have popped in. Do we have to place in transmission-based precautions for every admission, even if we require a negative test prior to admission?
Yes. Testing will not do anything to stop that 14-day observation requirement under transmission-based precautions, because that test is a point of care status outcome. It doesn't mean that if you're negative on day 2, because there's a 14-day incubation period, that you couldn't be positive on day 5. So that test has nothing to do with it. Everyone has to be in 14-day precautions.
Okay. Are visitors required to wear face mask and face shield?
Visitors are required to wear face masks. I see nothing that says that they have to wear face shields. But yes, anyone in the facility is required to wear a face mask. And of course, shields are required for resident care.
Okay. How do you get to the CMS call today?
I sent out the link this morning on the listserv. I don't. It's a link, so I can't just tell you how to do it. If you don't have access to the link to the listserv, I sent it out on all 3, by the way: housing, assisted living, and SNF. So if you don't have access to it, send us an email real quick, and we'll get it to you directly.
Okay. Very nice job, Deanna. As always, we very much appreciate you. Thanks for warning facilities about the concern over not having a designated unit for 14-day precaution admissions.
Okay, well, hang in there, everyone. I know it's been really a challenge, and it doesn't seem to be ending soon, but I can tell that everybody's doing a great job in trying to keep it all together.
So I understand correctly, all new admits have to be on a completely separate unit from everyone else, not just a separate dedicated hallway for 14 days?
Yes. Now, that's not what we're hearing directly from any guidance, but that's what we're hearing from people who've gotten cited for it. And we did talk to one of the attorneys who has been representing those persons. So yes, a single room will not do it. You have to have them cohorted.
All right. As of now, that is looking like the last question, so I will move it to this slide just in case anybody does think of anything else later on in the day or thinks of something else. You can go ahead and shoot an email off to either Safe and Calm, Deanna, or Dalton, and we'll make sure to get those questions answered for you. I did actually just have one more pop in. Any suggestions for what to do if we do not have ability to provide a dedicated unit? Could it be putting up a plastic wall at the end of the hall?
Oh, I think that there are things that you can do to make a dedicated unit. You can use the end of a hallway. There is guidance in CMS about what that could look like. But I think what would be most helpful is, and I think I put the link to this on Wednesday's webinar. So if you go back to Wednesday's webinar, it'll give you the link to the QIO site. And the QIO site has a lot of on-demand webinars about these things, and there's one about developing a cohorting system. And it talks about the requirements that you need to do that. So it can be the end of the hall. You can put up a partial barrier. You have to make sure that you have to consider how you do your workflows. So there's a whole lot of considerations, but I think that one webinar will cover them for you.
All right.
And just to let you know, and they may be listening, but you know, I do know Silly got a very high-level scope and severity citation for not putting their observation patients separated from the rest of the building.
Okay. We have 2 residents at a regional hub, and by regulation, we are required to allow them to return to the facility. Would the 2-week observation unit apply here as well?
No. If a resident has met the criteria to discontinue transmission-based precautions, you do not have to isolate them when they return from the hub.
Okay. Also, someone did say, "We are listening. It came last night and was an L."
Okay,
And then,
sorry about that. It was an L. So what they're saying is that that was an L level citation for not congregating the observation persons together separate from the rest of the uh, facility. That's really sad, but true.
okay. Is the cohorting you were just speaking of for sniff only?
One of the things, I'll try to do this on Wednesday, assuming that no one else sends out some, really immediate big stuff. But I did go through the guidance, all the different levels of guidance for cohorting for each level. And it's very complicated and very confusing and contradictory. Basically, the requirements for cohorting are based on nursing homes. So when we're talking about those stringent rules are only outlined. In fact, they're not even always outlined, but they're affecting nursing homes only because the surveyors are citing. Basically, I would say overall, HFAs, AFCs, and other assisted living settings are expected to follow basically the same cohorting rules as anyone else, but it's more of an expectation. You do have to have a dedicated unit based on the executive order if you're going to care for COVID in an assisted living kind of facility and environment. But otherwise, most of the rules apply to AFCs and HFAs in the same way, except for these little nuances where you have to put someone in precautions who's going out to a medical appointment. Those things are nursing home only.
All right. Just to clarify, is the requirement for the dedicated unit just for new or readmits, or also for those out for appointments, dialysis, etc.?
It's not clear, but I would think that it's the same kind of situation because those persons are in observation for the same kind of problem. So I don't know of any cases where people got cited for not putting people in a dedicated unit for observation going out in and out to dialysis, but I would think that it would be a similar enough situation that the surveyors would look at it that way.
Yep. Someone just said it is our understanding it is also for those returning from new appointments.
Right.
All right. What if you have a hallway designated for new admits? They come off precautions at the 14 days, and we do not have another room off the hallway to move them to at that time. Is it okay to remain on that hallway until a room is available?
Well, I would think so. That's one of those gray areas that there isn't clear guidance about. I would think that since everyone else in that hallway has to be using transmission-based precautions and that person's been there for 14 days already, I don't think a couple days would matter. I wouldn't leave them on for a long period of time, but I think it's probably the best alternative if you don't have another room for them. And that's part of the problem with all the cohorting is it ties up your rooms.
All right. So it looks like that is the last question.
I do have a comment real quick.
All right, go for it.
Just heard from Ruth Katz at CMS National, or at Leading Age National. Today's CMS call is going to be about cancer and not about the visitation guidance. So if you're not interested in cancer, I wouldn't recommend tuning in.
All right,
thank you, Dalton.
Yes, thank you for that update. And like I said earlier, I believe that's the last question. So if you do have anything that pops up later, feel free to shoot us an email and we will try to get that answered for you. Again, we always would like, is that call, it's at 1:30, correct, Dalton? The CMS call?
Yes, 1:30, it's about kidney disease and cancer.
All right. So now we would just like to thank Deanna and Dalton for all that information, and we would also like to thank all of our members and participants. I think that we actually crossed the line today over the 100 mark. I think I saw it at about 101 attendees and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for you for your continued support, and we are here for you when you need our assistance and resources. I know it's another busy day, but I hope everyone has a great rest of their Friday and a great weekend, and we will see you guys all next week.